Good morning, everybody, and welcome to today's webinar from the Massachusetts Health Data Consortium, featuring Alex Mugge, who is the Director and Deputy Chief Informatics Officer for the Center for Medicare and Medicaid Services. My name is Denny Brennan. I'm the Executive Director of MHDC, and I'm really thrilled to have Alex join us today. Alex has been at the forefront of some of the most significant changes in the way in which information is not only shared, but in the way in which health information is regarded by payers, by providers, and by patients. If you would go to the next page, I'll provide a brief overview of how today's webinar will be conducted. We have, as you can see, Twitter hashtags and Twitter handles. If you wish to play along on social media, these are the ones that will resonate the most with the webinar audience. We also have muted all attendees during the presentation. Please answer your questions directly. Please ask your questions, directly into the chat box. We'll collect your questions, and but most likely at the end of the presentation, because we don't have a long presentation today, we will open those questions up with Alex at the end of her presentation. As I mentioned, we are recording today's webinar. Do not say or write anything that you wouldn't want to be shared with anyone in the public. And lastly, we'll ask you to take a very few moments near the end of today's discussion to take a brief poll that we'll put up on the screen toward the end. Next page, please. Briefly, for those of you who don't know MHDC, we're something of an odd duck. We're a not-for-profit 501c3 corporation. We've been around for a long time, for 43 years. And during that time, we have established considerable goodwill among the health plan payer, the health plan provider, government, association, and other members of the healthcare community without taking sides with any one constituency over another. We are independent and unbiased. We have significant and growing expertise in health data standards and regulations. We bring a local focus. We are a Massachusetts not-for-profit, but we believe in sharing the good work that we and our members do with the rest of the world. And we're delighted, those of you who've joined us today who are not Massachusetts natives. It's always great to have you folks here. And we pride ourselves on invention, innovation, and incubation, the 3 I's. And what that basically means is we want to take the learnings of our community, plans, providers, patients, and others, and use those learnings to build, to design, to deploy services and technology that make it easier for organizations to become interoperable. And the steps between having your system set up, having your internal house in order are absolutely essential, but they're insufficient for interoperability. And one of our charges is to find those gaps where interoperability breaks down and to identify what services and what technologies can help organizations close those gaps. Next page, please. How we do that and what do? We have a data governance collaborative that is chaired by Janice Karen, who will be taking your questions today. The purpose of the Data Governance Collaborative is to understand interoperability and make it work. We do a number of things in the Data Governance Collaborative, including standing up a real-time prior authorization prototype with our exchange services so folks can get a chance to understand how that really works. But we're also building data standards that reflect and data specifications that reflect at a minimum the US CDI, but also allow organizations to standardize other data where more precision is needed, where the US CDI has insufficient specificity, And our goal there is to help organizations become, good actors on the network and understand how to make the most of their systems and the data that others have. We have an exchange services. We merged with the New England Health Exchange Network earlier this year, and that enables us to bring a community governed data exchange into MHDC that has been very successful at providing EDI and electronic data interchange services to providers and health plans. Lastly, we have analytics services. We provide a web-based service for hospitals, medical groups, health plans, and others that provide insight into how efficient, how effective, the level of quality, the level of equity that our hospitals and health systems provide. And it enables strategic planners and others within those organizations to look at a number of factors that constitute, how to be a competitive and good hospital or health system or medical group. Underneath those, we provide these webinars. As you're joining us today, we have a forum which is dedicated to CIOs and CTOs in our healthcare organizations and the things in policy and technology that are especially important to them. And we have a Vantage Point series where we provide interviews with some of the industry leaders. We've had Mark Gans from Cambia Health Solutions. We've had John Glasser, the first CIO of Partners Healthcare, now MGH Brigham. And we will be having Alexandra Drain joining us soon. So these are interviews that bring us closer to what's happening in the industry at a strategic level and allows us to step back a ways from the data that constitute our day-to-day lives. With that, let me provide an introduction to today's speaker. Alexandra Mugge is the Deputy Chief Health Informatics Officer and the Director of the Health Informatics and Interoperability Group at the Centers for Medicare and Medicaid Services, where Alex and her team have led the agency's interoperability and health IT efforts under the Office of the Administrator since 2018. The Health Informatics and Health Interoperability Group's message and mission is to promote the secure exchange, access, and use of electronic information to better support informed decision-making and a more efficient healthcare system. Before leading CMS's interoperability efforts in the Office of the Administrator, Alex served as the Deputy Director of the Division of Health IT in the Center for Clinical Standards and Quality, where she and her team led the overhaul of the Meaningful Use Program, something that many of our members appreciate a great deal, to create the Promoting Interoperability initiatives. Alex has broad experience analyzing trends, monitoring and evaluating healthcare initiatives and programs to promote better access to health information and to support value-based care. And with that, it is my great pleasure to turn the presentation. Alex, over to you.
Thank you so much. I'm going to go ahead and share my screen here. Hopefully you all can see. Oops. Hopefully you guys can see the slides.
Yes, we can.
Excellent. All right. Thank you so much for that introduction, and thanks for having me here today. I appreciate everyone joining to hear a little bit more about the work that we do and our goals for achieving a connected healthcare system. I'm going to go to this next slide here because I'd like to start off by telling you a little bit more about the team that's responsible for the policy and vision that I'm going to talk through about today. So we had a little bit of this outlined in my bio, but I'm going to go ahead and read some of our mission and vision real quickly, and then I promise to stop reading off the slides. But just real quickly, I want to read this and make sure that you all have a good understanding of the work that my team does. So the Health Informatics and Interoperability Group, or as we lovingly refer to it as HIIG, believes in promoting the secure exchange, access, and use of electronic health information to support better informed decision-making and a more efficient healthcare system. We envision a secure, connected healthcare system that empowers patients and their providers to access and use electronic health information to make better informed and more efficient decisions. So in practicality, we are a team that is exceptionally passionate about data exchange and the value that it can bring to all aspects of health and healthcare. We believe in interoperability, and we believe that it is going to change healthcare and the healthcare market. In practical terms, we oversee the interoperability and health IT efforts for CMS. We work across the many programs and stakeholders that CMS regulates, and we use this enterprise view to identify opportunities to drive interoperability. So if you know CMS programs, and it sounds like many of you do, and you're very familiar with them, you know that this means that we have a really good line of sight into most areas of healthcare. CMS has its reach into many areas across healthcare, and our team gets to look across all of those to identify opportunities for standardization and interoperability and enhanced data exchange with our stakeholders. So getting back to the graphic that you see on the slide here, it really is a picture that embodies the most important element of our work, and that is putting the patient at the center of all of our efforts. So all of us, all of you on the phone, and all of us at CMS, we're all patients. We're all people, we're all patients, and at some point, we are consumers of health information and health services. So we should really be the drivers of our own health care. But you know, for a lot of patients, and as you can see, sort of, or as we tried to depict on this slide, we have input from so many different data sources when it comes to healthcare. You get data added to your health record every time you see a doctor, every time you go to the hospital, if you get lab work done. You may be collecting health data right now on your watch or your phone. We have health data coming at us from all different corners of our lives. And this is all really important data, and it's important input, but it can be overwhelming to patients. And often it's tempting for patients to set that data aside and let clinicians figure it out. But we as patients, we have to engage and take responsibility in our healthcare decisions to ensure that we're getting the best possible care for our individual needs, which are all unique to us as individuals. So our team here at High IG in CMS believes that the healthcare industry is at a tipping point, and it's a tipping point that's going to benefit you as the consumer. We're no longer relying on paper records and committing our medical history to our memory and then hoping that when we get to the doctor's office, we can fill out that clipboard that we're handed with all that medical history just from memory. We're moving into a future in which technology brings all of our data together in a connected healthcare system and in a format that is easily accessible and available for us as patients to access, use, and really understand. And why are we going in this direction? I think if you look at all the other industries that you interact with, people have higher expectations for technology in their everyday lives than they did 10 years ago. You probably haven't gone to a bank very recently, or most of your banking is probably done through an API on your phone. You don't usually call a restaurant or call a cab. If you want to make a reservation or get a ride somewhere, you're probably using your phone and the APIs that you have available. And that's for your convenience and for your privacy. So why don't you have the same expectations for healthcare? Why don't any of us have the same expectations for technology and healthcare? And that's really what I want to talk to you about today, is how technology can work for patients and actually assist patients in making sense of all these data inputs that we have and start creating a healthcare marketplace in which patients are the true consumers in a competitive healthcare market. So getting back to my team, and again, on our beliefs, we believe that in the not so distant future, people will have the same expectations in healthcare that we have in other parts of our lives and in the economy. And we believe that technology and the access to data is going to help make that happen. This will benefit the patient because they'll have access to higher quality and better value services. And it will improve your patient experience the next time you go to the doctor. This also, we hope, will benefit providers who will tailor their customer experience to fit their unique patients. Because there's a lot of data out there for patients to measure and keep track of. There's also a considerable amount of data for hospitals and providers to manage. And you can't manage what you can't measure. So having data available in an easily understandable, digestible format is really critical to this future healthcare vision that we have. Let me go on to the next slide here. So what exactly does CMS do? How does CMS support this future state vision that I was just describing? And I'm going to talk about this in the context of what my team does, but there is a ton of work going on across CMS to support all of this data exchange and this data availability in healthcare. So my team works internally. We look at all of the CMS programs that we have, and we work with our federal partners like ONC and the VA and the CDC, all of the other federal acronyms. And we work across those stakeholders and across those federal partners to advance interoperability policy and strategy and find ways that we can increase efficiencies by collaborating across these agencies and across all the programs that they regulate. CMS has a wide reach of programs that we regulate, but when we work with our partners at VA, CDC, and ONC and others, that really expands that reach into other programs and allows us to build that alignment that will get us to interoperability. We also try to foster innovation in our own programs here at CMS, and I'll talk about some of those programs more in a minute. And we also work across with industry partners to build pilots and work with industry and work on some of that data sharing collaboration. And finally, we support implementation by working with standards organizations. I'm going to talk about that some more in the next slide. But we continue to work with our stakeholders and try to ensure that we have access to the resources, that they have access to the resources that they need to really successfully implement these interoperable systems. Let's go to that. So let's talk a little bit about the FHIR standards and the standards that support this work. CMS and our federal partners at the Office of the National Coordinator, or ONC, we have both identified the Fast Healthcare Interoperability Resources, or FHIR standard, as our chosen standard to support our interoperability efforts. And we did this because we believe, or we know, that using a standard imposes a consistent representation of data, even if it is sourced from different origination points. And this promotes the ability to exchange and use healthcare data. So if you think about all the different places that your data is coming from, it's coming from, your phone, your doctor, a hospital, or a lab. All of this data may be collected and aggregated differently, but then when it comes together with the use of a common standard, it actually provides that ability to put it into one format so that it can be used and digested and available to the consumer. So I've put a heavy emphasis on this word use because simply sending the data back and forth isn't enough. The data has to arrive in a format that it can be used by the recipient. And we essentially have to take all this data and turn it into information that makes sense to the end user and allows them to consume that data in a way that's meaningful. And FHIR is specifically designed to support this type of information sharing. It provides an interoperable platform for healthcare, and it defines a common structure for healthcare data known as resources. So FHIR sorts this data into these resources, allows that data to be exchanged, and then manipulated in ways that it can be used by the consumer or the end user. So again, we at CMS and our partners at ONC, we really look at FHIR as an opportunity to align on this single open source standard that is adaptable to all the many programs and the needs that we have in healthcare. I also want to mention that there are several industry organizations that have that are put in place that help to drive and further the development of the FHIR standard, and these are called FHIR accelerators. Many of you may take part in some FHIR accelerator programs. These organizations, they each have a particular focus, and in general, they drive a discussion around how to accelerate the development of FHIR and the FHIR resources in those particular areas. CMS itself and my team actually supports these organizations, and we actually actively participate in 4 of these organizations, either by providing resources or by having a seat on the board. So when I say that we're really collaborating with industry to promote the use of these standards, I mean that we're doing that in every possible way, from sitting on the board and providing resources to developing the standards themselves to implementing those and working with industry partners to implement them. So let's go a little bit more to our commitment to FHIR. CMS has been looking at the FHIR standard for years, but it wasn't until the last few years that we really started to integrate FHIR with our own regulations and even our own operations. In large part, that's because of the work that was done by industry and the organizations that I just mentioned, and the work that they've done to really develop and test and accelerate the use of FHIR. We've been able to include a lot of this work in our own programs and regulations, and through this drive with FHIR, we've been able to help industry align in that common direction and really focus on this standard. We've begun to integrate FHIR into many different aspects of CMS's work, and some of them are listed here on your screen. So we have from our own FHIR Blue Button implementation, and that's CMS's version of a patient access API that allows patients or Medicare beneficiaries, I should say specifically, to download their Medicare Part A, B, and C data. And they can download that using any application of their choosing, and that application can put that information into a format, again, that those beneficiaries can use to better their own healthcare. We've also got other FHIR-based APIs that we've been standing up, like data at the point of care. That's an API that allows CMS to send Medicare claims information directly to providers. So they have that information about their patients available when they're trying to make care decisions for their patients. They have a broader view of that patient's claims and Medicare claims history. So we've integrated this into several of our programs, all the way down to that last bullet on your screen, the interoperability and patient access final rule. So this is a rule that CMS finalized a year ago, last May. And I'm going to focus, actually, I'm going to bring up the next slide and go ahead to this next slide and talk a little bit about what was included in that rule. Because it's hard to believe how far we've come with this. And many of you may be familiar with this rule already. I don't want to spend too much time walking through each of the policies on this slide. There's a lot on this slide, and I think many of you may have already heard this from other presentations. So I don't want to walk through every policy here, but I do want to give you kind of an overview of the scope of the policies that were included in this rule. We have, and as you can see on the screen, so this is the timeline of the implementation dates of each of the policies. But again, I'm just going to talk kind of broadly, and you can see where we are on the implementation. We've already passed many of the deadlines and implementation dates for this rule. But this rule included policies that were applicable to clinicians, to hospitals, to state organizations, and all the way to policies for payers, which includes Medicare Advantage organizations, Medicaid and CHIP fee-for-service organizations, and Medicaid and CHIP managed care, as well as the qualified health plans on the federally facilitated exchanges. So this rule really includes a broad scope of the programs and stakeholders that we at CMS regulate. And I want to drill down a little bit into the payer policies just a little bit more for a couple of reasons. One is that this is where we really brought in the use of the FHIR standard into these policies. And also because this is the first time that CMS is regulating the use of interoperable standards for payers. So why is that in particular point important? This rule represents a shift from our historic focus on only EHR availability for clinicians and hospitals to include the sort of broader interoperability and bringing payers into the fold. So historically, we've really put a focus on clinicians and hospitals adopting and using EHR technologies and interoperable standards through our Meaningful Use program, which many of you know and love, now referred to as the Promoting Interoperability Program. But we really put a big focus on that in our policies of the past. And now moving forward, we're shifting away from that sort of program and measures-based interoperability and moving more towards this broad idea of interoperability in which all stakeholders, including payers, play a role in exchanging that data. And payers have so much data that this is it's a natural place to start with this sort of new broader view. Payers have data that comes in from providers, and they have data that comes in from their patients, and they're really sort of at the hub of where this information comes together. So integrating payers into the interoperability fold is critical for moving forward and really broadening that interoperability view. And we like to say that interoperability includes everyone, and we really have to move away from that program or singular entity view of interoperability and really think about how we can integrate all players in the healthcare marketplace into the interoperability space. So I did say that I was going to drill down a little bit into the payer policies. So there were 2 API policies that we proposed or finalized in the CMS interoperability and patient access final rule. And the first, those two requirements included the implementation of the Patient Access API and the Provider Directory API. And these are both standards-based APIs using the HL7 FHIR standard. These APIs were required to go live on July 1st, and they should now be available from all the payers that were regulated in this rule. So if you or someone you know is enrolled in one of these payer programs, they should have access now to a Patient Access API, which would allow this person, this patient, to download an application from just your regular app store that can link to your payer and download your information and put it into a health app that can really represent that data in a way that makes sense to you as a patient for your specific needs. So if you need to download a diabetes specific management app, you can do that. And I believe those are available, and integrate this data into that application to really give a better picture of your particular healthcare based on the data that's coming from your payer. So that can be these can be really beneficial tools to patients. And now that they are available more broadly through all these payers, we're hoping to see more patients engage in their healthcare in this way. Now, that said, we know that these policies don't cover all of the payers that are out there. CMS regulates a lot of payers, but it doesn't cover all payers. And by extension, that means this does not cover all patients. We believe that this is a significant step towards engaging payers in this interoperability space. And we know that if they've implemented it for one line of business, there's a good chance that they have the ability to implement that for all of their lines of business. So while payers may not be required to implement these APIs for all of their patients, we certainly hope that once they built it for any of their Medicare, their CMS regulated lines of business, that they will roll it out to all of their patients. And that can be a huge impact for all patients having access to their data. So that's, and I know I focus on the Patient Access API. There's also the Provider Directory API, which provided all of the provider directory data from a given payer in this API format, which would allow developers to pull together all of those provider directory data, and patients would be able to, I don't believe this tool is out there, but think of a Travelocity type tool for provider directories. If you're trying to find a new health plan and you want to know if your providers are in network, and you can compare those directories, or just use this type of tool to locate a new provider within your current plan. That's what these APIs would allow you to do through the Provider Directory API that is, again, now available from all these payers. So those are the two API policies that were in the rule. And as you can see, those are already implemented in the past. And where you see the line that says you are here, moving forward, you can see the next deadline for payers is January 1st, 2022. And that is the deadline to initiate the payer-to-payer data exchange policy. So this policy states that when a patient, at a patient's request, if that patient is moving from one payer to another, the patient can request that their data come with them from their old payer to their new payer. It allows them to essentially bring that data with them as they move through their healthcare journey from one payer to the next, and create a cumulative healthcare record at their current payer. We did not, notably in the rule, we did not require the use of an API for this policy, but we did require that payers would exchange this data again whenever a patient requests it to go with them. So you don't lose your data when you move from one payer to the next, but you actually have the ability to bring that data with you. All right, moving on to sort of the future of CMS interoperability efforts. So as I mentioned, to truly get data exchange to a point that it can benefit patients with better outcomes, we really have to ensure that the data is flowing to more than just the patient, that we're engaging all stakeholders in this interoperable data exchange. We have to ensure that all providers and payers and caregivers have access to the data that they need to make the best decisions for their patients. I just on the last slide, just at the end there, I did mention that the deadline for the next payer deadline is the payer-to-payer data exchange policy. And I mentioned that requires payers to exchange data, but did not require a standards-based API like we had for our other policies. So that brings me to a rule that we published last December. It was a proposed rule. It's still just in a proposed format. So last December, we released a second interoperability rule, and that was the CMS interoperability and prior authorization proposed rule. This rule takes our journey beyond patient access and puts a broader focus on the challenges that we continue to see in health information exchange. This proposed rule expanded on the policies from CMS's first interoperability rule and introduced new provisions that would expand the use of application programming interfaces, or those APIs, as well as streamline the prior authorization process for CMS regulated payers. So specifically on the payer-to-payer front, this rule really built on the policies for payer-to-payer exchange by proposing to require the use of an API for that data exchange to happen. It also proposed to include more comprehensive data in this data exchange, to include claims and encounter information, as well as prior authorization decisions. So as a patient moving, again, from one payer to another, not only would your data now follow you electronically through the use of this API, but it would also include more of your claims and encounter information and those prior authorization decisions. Nothing more painful than switching payers when you've just gotten a prior authorization for something and you go to a new payer that has none of that information available. Now, through this rule, that data would be available. But to be clear, this rule has not been finalized, so it has no impact on the requirements for the January 1st deadline that is upcoming. But it is a next step in our journey towards interoperability. So we really went from, when you think back historically on the policies that we've seen over the last 10 years, we went from meaningful use for clinicians and hospitals that allowed them to adopt and use EHR technology and then begin to use that technology to exchange data with one another. And then we've introduced payers to the point into this data exchange framework by requiring them to implement these point-to-point APIs. That was in the first rule. So point-to-point being from the payer to the patient directly. And now we're going even further to make data exchange a two-way street in which providers send information to the payer and receive responses back. So we're really starting to engage in more of that bi-directional data exchange. That's really what gets at the heart of interoperability and care coordination for patients. And that's what we want to look at for our interoperability journey into the future. We're looking at ways that we can build on this groundwork that we've laid through these rules and continue to grow the interoperability policy going forward for the stakeholders that we regulate and those that our partners regulate as well. So this slide shows some of our priorities moving forward. I can briefly touch on these regulations. We've sort of already touched on what we've done and what's available out there. We're going to continue to build off the policies from that first interoperability rule. And also continue to look at the policies that were proposed in the December 2020 proposed rule. Since we did just talk about that, I will go on to the next, but I will say we're enthusiastic about the opportunity for our regulations to really help move the needle and to help align industry on common standards and common implementations to address some of what we've heard from industry are challenges in the healthcare marketplace. So really understanding that prior authorization was as a pain point for many in the healthcare industry. We believe that these regulations will help align and to streamline some of those processes that have been historically somewhat of a pain point, and introduce these technologies that will simplify and strengthen those policies or those processes in healthcare. So they're less of a pain point and more of a valuable tool in healthcare. Also on this slide, we've noted public health, and public health is really at the heart of the work that CMS does every day. But as we're hopefully coming out of this COVID-19 pandemic, we all know that the pandemic exposed many weaknesses in our public health system, and it highlighted the urgency with which we need to be more nimble in exchanging data and being capable of analyzing that data more efficiently. So that gets back to, exchanging data in this common standard allows us to really receive and analyze that data more effectively and efficiently so that we can respond more quickly to heaven forbid, any future public health crises like what we've experienced over the last year and a half. CMS has also been participating in the ONC HITAC, the advisory board, and working on a advisory task force on public health data systems. We anticipate that some of the insights from this conversation going forward are going to inform our regulation and our operational strategies and help us to be better prepared for the public health infrastructure changes that need to take place for the future. And then we note on here supporting innovation. So at CMS, we continue to innovate our own technology developments, and we continue to build on the APIs that I mentioned a few slides ago, and build new technology solutions that will support more streamlined workflows and support better data exchange within our organization as Medicare fee-for-service, as us as a payer, and also with our partners in industry. And then the next note on here is refining implementation guides. I also mentioned that our office continues to work actively with the HL7 Fire Accelerator projects, and to the extent practical in support of the work that they do to develop, refine, and test these implementation guides. We recommend the use of those guides in our rules and in our outreach. And so we believe that we have a critical role in supporting those and ensuring that they can be developed efficiently and that they have the resources they need to be developed and be available to implementers to successfully implement our policies. As new projects come up, we're going to continue to work with these organizations and look at ways that we can facilitate engagement with that work and see how it fits into our overall mission, and really ensure, again, that we're developing standards that are going to support the policy. So technology continues to innovate, policy continues to change, and that's just because of the nature of this work and interoperability. It's a fast-changing space, and we have to keep pace both from the technology perspective and from the policy side. And then finally on this slide, we have on here leading by example. So we're very lucky to be where we are at CMS. We're both a regulatory policy maker as well as a payer who has to operationalize the things that we regulate. And that means that we really get to practice what we preach, and we can use Medicare fee-for-service to build out some of the things that we want to see also build out in the marketplace. For example, like our Medicare fee-for-service Blue Button initiative that allows beneficiaries to access their own data. We built that first at Medicare fee-for-service, and then we put it in a proposed rule and finalized that rule to require other payers to build a patient access similar to our Blue Button initiative. And that leading by example is really critically important as we navigate some of this new way of bringing payers into the interoperability space. It's critically important that we at CMS ensure that we can build that out for our Medicare beneficiaries as well. And that brings us to the more connected healthcare system that I mentioned at the beginning of this presentation. So we've talked a lot about the policies that CMS has put in place and our views on the use of FHIR. And you'll note that not all of our policies in the rule really utilize the use of the API technology, but where we do, it's a FHIR-based API. I've given you a bit of an overview of some of the policies from our rule, as well as some of the things that we're doing from Medicare fee-for-service and in that space. And then I just want to talk, again, get a little bit more broadly, talk about what true interoperability means again, because as I said previously, it's not enough to send data around so everyone just has access to it, but it's really critically important that we can take that data and turn it into actionable insights. And that is what we're trying to do, again, by putting this data into this standardized FHIR standard and exchanging that data with and among all of the stakeholders in healthcare. We have to make sure that this data is available and usable and really meet the patient where they are and give them the information that they need to make the best informed healthcare decisions. So by exchanging this data in an interoperable way, I've said the word so many times, I'm tripping over it now, apologies for that. But by exchanging data in this interoperable way and using defined standards, we can allow industry to take all of this data that we mentioned throughout the presentation and all of the data from all the different systems that are in healthcare and align it to one set of information to really help inform patients and inform their providers and caregivers. We know that some patients are ready to embrace this technology to better their health, and some might need a little bit more help. We believe that innovation and robust engagement by the developer community can help the healthcare industry meet each of those patients in their unique circumstances where they are and help empower those patients to be better consumers of healthcare services. So that's a responsive market, and that's what will drive us to value-based care. We also know that truly achieving interoperability to a point that it can benefit the patient with better outcomes, we have to ensure that data is flowing to more than just the patient. So increasing that data availability. Patients, of course, deserve access to their health information, but they should not be the only bearer of their information. They shouldn't be the only shepherds of that data. Therefore, we have to ensure that all providers, payers, caregivers, all those stakeholders have access to the data in order to help them make those best informed decisions for their patients. Increasing data availability, increasing a data availability and the seamless data exchange that we've noted here on the slide. Increasing that data availability will support all stakeholders in improving patient care and providing better patient care coordination and responding to this new market in which patients have more power and more control over their choices. So like I said at the very beginning, we're at a tipping point in healthcare. Technology is now in place through the meaningful use programs. It's available to clinicians and hospitals, and through these other policies, it's now available to payers and to consumers. This data is now coming available, and that's going to change the way that healthcare looks in the future. And this is where innovators and implementers, like many of you on the call today, hold the key to driving this change. We need folks like those on this call and those in industry to really implement these technologies and help meet the patient where they are and use this data to inform and to support better patient care. And this will drive us to the finish line of this connected healthcare system that we're mentioning, and this will lead us to value-based care. It's really what we're looking for our patients and providers alike, and will really change healthcare on the whole going forward. So that's the future that we envision, and this is some of the work that CMS has done to support that vision. As I mentioned, there's a lot more work going on at CMS, and there are a lot more things that we can engage with industry to support for the future. I'm going to leave up this slide as we go into the Q&A. This is a way that you can contact us. You can visit our website and reference our frequently asked questions. This is particularly helpful for those who are implementing the policies of the interoperability rules. We've added several frequently asked questions since the initial posting. So if you haven't looked at it recently, please take another look. Your question may be answered there. And then if it's not answered, or if you just want to reach out to us, I know there was a slide at the beginning with some of my contact information. You can also email the CMS Health Informatics and Interoperability Group, longest email address in history. You can email that address with any questions, and we will get back to you. And if we have enough of the same questions, we'll also update those FAQs with some of the information that we have there. So thank you all for listening to me ramble on. I'd be happy to answer any of your questions at this point.
Well, thank you, Alex. We're going to turn it over to Janice Karen, who's been collecting questions from a number of folks. And Janice, why don't you take it from
we
there?
have a ton of questions. I'm just warning you now.
Oh, great.
So the very first question, which was asked by quite a few people, is are there any updates on, now you mentioned the proposed rule, but there was actually a final rule that came out for the prior authorization pieces that was frozen with the change of administration. Are there any updates on the status of that rule, either the frozen rule or a revamping based on the proposed rule, in terms of when we might expect something and what the status is?
And that's a super great question. I really ought to bake that into the presentation, because I do think that's always the first thing that's asked. But so thank you for noting that there was also a final rule. That final rule actually did go on hold and before it could officially be published in the Federal Register. So that final rule does not take effect. It's still under review by the administration. So there will be an update soon, but I can't tell you what that update is. Of course, I wish I could, but I wish I knew. But we are continuing to work on that policy. We know that those policies are critically important. That's why I did mention them as part of the slides today. So we know that a lot of stakeholders are interested, particularly as it relates to the prior authorization policies and other things. So hopefully more to come on that. And I wish I could share more today, but you'll be among the first to know whenever something does happen.
All right. So the next question is, this one's for me. I just saw an announcement about a 6-month enforcement delay for the No Surprises Act provisions. Is that just for the price transparency related provisions or for all of the other stuff too, such as those related to provider directories, insurance cards, continuity of care, et cetera?
So the announcement that is public, there's an FAQ on a different website, not the one that's on your slides here, but a different FAQ that was posted that I believe was related to the advanced EOB and the price transparency provisions. So that's all I can speak to at this time. But yes, that was an enforcement discretion stating simply that the deadline, is not achievable at this point, and so we will delay enforcement until we can provide more information.
All right, so there are a couple of other questions around No Surprises, so why don't I get all of those out of the way together? Is there any news on when we can expect some of the additional rules covering other aspects of the No Surprises Act? The current interim rule, despite its length, barely scrapes the surface of the functionality discussed in the law itself.
Yes, so there will be additional rulemaking, but we can't comment at this time of when that will be or what will be included, unfortunately. But I know we're all eagerly anticipating that.
Well, you may have exactly the same answer for this one, but I'm going to ask it anyway. Can you talk about some of the interoperability aspects of the No Surprises Act? What new types of data exchange do you think it will bring?
Well, I mean, I can speculate a little bit, but this, again, you would have to wait for rulemaking to really see what the CMS policies are. But just in what we've seen in the discussions happening in the standards community, and through some of the work that we've done with the fire accelerators and with others, we know that there is just a ton of work already gearing up in this space. I think that price transparency standards on the whole are something that are critically important and something that we've been looking at for many years. So really working on the development, regardless of what happens with these rules or these policies, I think it's really important that we focus on looking at price transparency standards and making this data available in a consistent format, because consumers really can't compare prices and get at those goals of price transparency unless we get the data aligned in a way that is comparable. So that's where the standardization piece comes in, and really looking at what data are we making available, and are we making it available in a way that a consumer can put it, or it really would be the technology developer, but that a developer can consume that data and make comparison tools for consumers or patients. So I think that really focusing on those interoperability standards for price transparency is going to be important one way or another, and certainly hope to see the policies that support that in the future.
Okay, and one more before we move on, I promise. And this one actually is kind of a hybrid. Can you discuss how the provider directory elements of the No Surprises Act interact with the provider directory APIs from the current interoperability rule?
So I can touch on this a little bit. There's a lot of work to be done in the provider directory space as a whole. I think, there are definitely pain points, I think, from a patient perspective on provider directories and getting more accurate data. And then there's also the fact that, provider directories in their current form really don't support sort of that interoperability use case that's critical to some of the work that we're doing. They don't include those electronic digital endpoints for providers or payers or anyone in healthcare. So I think that there's definitely a need to look at the healthcare directory. I don't even want to call it provider directory, but the healthcare directory issue as a whole. And I would say that the provisions in this act and the and what we've had in our rules are kind of just addressing parts of the whole problem, and we have a lot more work to do in this space.
Great. All right. So moving on, I bet there's your sigh of relief. So we've seen a disturbing trend backing away from fire and trying to find fire solutions to interoperability needs and problems. Even sometimes industry groups that are focused on fire are discussing hybrid setups or even solutions for specific use cases that don't include fire. Are you seeing this? Do you have any comment or any way to encourage people to move back towards an API economy?
So I haven't seen really folks talking about moving away from fire, but more, I think, there are a couple of different things contributing to that. So, like particularly, you said we were getting away from the No Surprises Act, but we really aren't, because I think that.
Sorry, I tried.
In part, some of the discussions, I know, right? That's always going to come back to the latest shiny object. So in the No Surprises Act, there were some very short deadlines referenced for the implementation of certain functionality, like the advanced EOB. And I think that I've heard in a lot of the discussions lately where folks have talked about hybrid solutions or moving away from fire. Again, I don't think it's moving away from fire, but talking about hybrid
moving
solutions
towards it, maybe.
Because, because people are looking for something that's available here and now and today. And fire is a relatively young standard in the scheme of things, but it has the capability to do all of the things that we're looking for. But in some cases, the guidance or the use case for that isn't quite established yet. And I think that people are looking at a way to bridge the gap. Like, if we have to implement something on January 1st for advanced EOB, how do we get there with fire and the resources that we have now? And I think a lot of folks were thinking we need to do a hybrid approach because we don't have an all fire solution available yet. And I would say a couple of things about that. One, you now have more time. So let's work on it. But two, I think, looking for the easiest or the most readily available solution isn't necessarily going to lead us to what we can use over the long term. So even if folks are looking at a hybrid solution or something that's not fire, I would encourage you to think about that as maybe a short-term solution and think about what is the longer term availability for these standards and when would fire be able to be in place. So can you hold off for that, or do you need to implement a phased approach and go to some sort of combination solution and then move to all fire? And we're we're taking that approach as well in the CMS interoperability and prior authorization rule. We did propose a prior authorization solution that was a hybrid approach. That was with fire and the X12278, which supports prior authorization. And the reason for that, in that particular case, that wasn't about capabilities or a timeline of implementation, but that's because the HIPAA transaction standards require that we use the X12278 if we're going to do an electronic prior authorization. And so in order to get the end user experience of fire and some of the capabilities of fire on the sending and receiving end of that API, we also had to include that translation in the middle. I call it like a sandwich, or like bookending this transaction. We also had to include that HIPAA X12278 in like the meat of that sandwich. I really should come up with a better way to describe that. But the 278 had to be present, and so we did that with the fire on the outsides of the transaction, and that's because of a policy hurdle or a challenge on the policy side, and that we must include the 278 for right now. I know this is a very long answer and I apologize, but I do want to mention one other thing, and that is that the Da Vinci community, which is one of the fire accelerators, has submitted a request for an exception and been granted that exception to the X12278. So if you are in the Da Vinci community and you've signed up as part of this exception, you can now move to an all fire solution for prior authorization.
I was actually
that does not have an effect.
Sorry, Alex, go ahead. Go ahead. Sorry, finish your comment.
I was going to say that doesn't have an effect on the rule itself, because the rule was structured, with HIPAA in mind for those who are not part of this exception process. But the longer term may mean that we're moving towards an all fire solution, and we in the policy field have to make sure that we're setting up our policies in a way that we can be nimble with those changes. If we do ultimately, and not projecting anything here, I have no idea, how or when this would happen. if it does. But if we do move to an all fire solution, as the industry is in the whole, if HIPAA moves to an all fire solution, we need to make sure that we're setting up our policies in a way that we can be responsive to that, and that we don't lock someone into the use of a hybrid solution where an all fire solution might also be possible. And that's a really challenging thing to balance, this policy with the technology, because technology is going to continue to evolve, and policy isn't usually as fast as much as we try. Policy making just takes a lot longer in a lot of cases. So we have to make sure that we set ourselves up to be agile with the changes in technology. And that's another thing that my team really focuses on and tries to work through.
That's a perfect setup for a couple of other questions. But before we
Hey,
do that,
Janice, yeah, could I interject for a second? Just see if, Alex, do you have a hard stop here at 2? I just want to make sure we don't
it's
cut
supposed
over.
to be
I
going
do
till
not.
2:30.
Okay,
Oh,
all right,
okay.
well, we can continue. Go ahead.
All right.
I don't know if we're going to make it all the way to 2:30 if it's going to be rapid fire questions, but we'll try.
Okay.
Well, I think I have enough questions to get us there if you can stay till 2:30, but we'll see. So actually so that was a perfect segue to a bunch of questions that we have, but actually when I interrupted you before because I thought you were done, we actually had a specific question about the HIPAA stuff. So can you talk about HIPAA exemptions, I guess, beyond Da Vinci, if there are any, or changes to HIPAA? There was a HIPAA proposed rule that was supposed to bring HIPAA into alignment with the interoperability rules, but it didn't address the X12 requirements for prior auth. Do you have any sense of what, if you have anything else that you didn't already share with us in that area?
Yeah, so on the exceptions front, so the only approved exception that I'm aware of, that is approved right now, is this Da Vinci prior authorization exception. But anyone can file an exception. I'm not going to lie, it is a lot of paperwork, but and there's a process for it, but it is a public process that's available to anyone. So Da Vinci is not special, they just moved first in this particular space. So anyone can file an exception to the HIPAA transaction standards, and and the goal of that is really to test things out and in real implementations, and then make a recommendation if that's the way to go. So if Da Vinci determines that this all fire approach to prior authorization is the way to go, then they would submit that information to the Secretary's office, and that would come to actually our team at CMS also addresses that. It's a partner team to ours. It's the National Standards Group, who is in the same office of burden reduction and health informatics with us. Anyway, that team would review those recommendations, that information, and work with our advisory boards like NCBHS to see if this is a recommendation or a way that we should go. And then it would have to go through rulemaking, because of course the X12 278 is the adopted standard for prior authorization. That process happens through rulemaking. So to change that, there would also have to be rulemaking. But first, we go through this exceptions process and see if we can gather the evidence that says that this is the right thing to do. And again, so anyone else can do an exception for any of the HIPAA transaction standards and test out other solutions. So I won't make suggestions for what that could be, but I know there have been conversations, people have asked questions about getting exceptions for claims processing. Could claims move to FHIR? And that's a really big animal to process. But certainly, there's an exception for that. You could file an exception for that. So that was part of it. And then you asked about other rules and things. I know industry is anxiously awaiting the attachments rule. That would be another HIPAA transaction standard that would be declared. And I think everyone knows that CMS has been working on that for quite some time and hopes to share something with industry soon. I'm not aware of any other efforts though to bring everything into alignment currently with the interoperability standards. I will say my team's I think we're very lucky in the way that we get to work, because none of the things that we've put into policy are actually statutory requirements. So Congress didn't tell us to do this interoperability rule, but we used existing authorities that CMS already had in each of the programs to come up with the policies that you see in the rule. And that's, we're taking a look at old authorities, I'm saying old, but like authorities that were put in place kind of before this concept of interoperable technologies supporting healthcare, and we're saying, looking at this in current day, what does this mean, and how do we turn this into supporting these patients through interoperability? What authorities do we have? And so we have, I think, a bit more flexibility than the folks on the HIPAA side, who are really working with more rigid and defined requirements for what they can propose and how they go about it. And it's a great process to have in place, but it is something that has to be continually evaluated. And that's what we continue to do.
So we have a couple of questions about US CDI and moving towards the future. So the first one is that the current interoperability rule explicitly requires using US CDI version 1 or the US core equivalent via guidance. But ONC has already released version 2 and version 3 is already under development. Do you see bringing this into alignment? And if so, how do you deal with support for different potentially incompatible versions in different systems?
Yeah, that's a great question. And again, that kind of comes back to, as technology evolves, how do we keep pace with our policies? So we included the US CDI version 1. And I think ONC not only is, moving on to version 2, but also is looking at ways to accelerate some of the US CDI process to make sure that we're incorporating more data elements and really moving towards standardizing that data. And so we'll have to keep pace with that with our regulation. There are ways to advance standards without it having to go through rulemaking. So one of the things that we talk about is the standards versioning advancement process, or SVAP process. And that is discussed in our Rule 1. I think we actually pointed to ONC's rule. We like to do a lot of this pointing to different things, and you kind of have to follow us and our logic there. But, ONC described a process by which if you can move to the next version of a standard and it's still compatible essentially with the prior version, that would be, acceptable. You can continue to advance those standards as long as you're not breaking old connections, essentially some backwards compatibility. At least that's how that works for the CMS side of the house. We adopted that process in that vein, that if you want to move to like the next version of FHIR or the next version of any of the standards, you can do that as long as you're not breaking old connections. So we understand that there are going to be advancements that we don't totally keep up with, including the US CDI, and we hope that folks will be able to use that process to keep advancing and keep pace.
I would just point out that both FHIR and US CDI are currently doing backwards compatible updates, but thank you for that answer. There's another question that's related, which is about US CDI and US core. Hang on, let me find it. So the rule specifies US CDI, but guidance indicates US core is an acceptable alternative. You may have already answered this actually in what you said, but let me ask it anyway. US CDI is likely to update to keep, US core is likely to update to keep pace with the new US CDI versions. Do you have any, like they're gonna flip flop is my understanding. Do you have expectations of how that will work beyond what you've already said?
I don't. I think you're right.
Okay.
We've been pointing to US CDI, and we'll have to see where things evolve from here.
All right, so let me move on to another topic. We've had several questions about consent and privacy, and rather than ask them all individually, let me just sort of ask a general question. Can you speak to consent issues in the interoperability and exchange programs and requirements that you oversee? Some of the particular points that people asked about were, how do you inform patient choice while maintaining the flow of essential data to payers and providers? And then one person also asks about, specifically about interoperability and EDI.
Okay. So I can address that with one broad answer. Obviously, privacy and security is central to this whole concept. Without it, we would lose everything. So privacy and security is critically important to these policies and to interoperability on the whole. Full stop. That's an important thing to just note. And I think one of the things that we hear often is that there is this friction between a patient's right to access their data and their privacy and security. And I think it's really critical to point out that patients have the ability to weigh that risk, but patients, most importantly, have a right to access their data. So this really should never be used as an excuse not to share data with the patient. I'm going to talk quickly. I know a lot of people think about the patient access API in particular when this question comes up. And one of the things that you saw in the December proposed rule / January not final rule was that we had proposed a policy about payers collecting attestation statements from app developers, and saying that payers could make this available, this attestation system whereby an app developer would say, you know, if they have a privacy terms and conditions and whether they're going to share data with other entities. And so the payers would then have the apps attest to this, and then the payer could, you know, relay that information back to patients. And that is, you know, certainly I think it helps with patient and education, and helps patients to be aware of how their data is going to be shared, and it brings that extra attention. But also we need to keep in mind that if a patient's requested to share their information with that third-party application, that means they've already vetted the application. They've already gone to an app store, they've downloaded it. They have, if there is a privacy terms and conditions, they've reviewed that and consented. And then they have put in all of their information and asked that app to connect to their payer to get their information. Once they've followed these steps, it's really important that we ensure that we are allowing data to flow to patients, and we're not ever using a privacy or security as an excuse not to share. So I do want to put that out there, because I think, you know, it is just so important for patients to have access to their information, and it's important also for them to be able to choose where their information goes. It's equally important for patients to be educated about how that information will be used. And so I think that's also a piece of patient education that CMS and providers and payers and anybody engaging in this space has a responsibility to help patients in any way that they can, to educate them on what tools are available and what's happening with their data. So, you know, that said, I can ask right now for my data to be sent absolutely anywhere, and it's supposed to be able to go. Per HIPAA, I'm supposed to be able to send my data anywhere I want. And this really doesn't change anything. We're not changing anything about privacy laws in any of the rules that we've put out. It's all the same rules. It's just applied through an API as opposed to an email or some other electronic transmission.
All right, great. Thank you. So we have a bunch of questions around uptake and enforcement of rules that are already in place. It's almost 2 months past the I'm going to ask them all together, so bear with me. It's almost 2 months past the enforcement date for patient access APIs and provider directory APIs. Can you talk at all, excuse me, talk at all about how much payers are complying versus how many violations you've seen and what the more common violations are? Continuing with the sort of the same vein, do you have any sense of how many payers are choosing to support these APIs for all of their members versus just those under the mandate? And then finally, someone also would like to know information of similar information about event notifications.
Okay. So I will say we are 2 months in, and that sounds like a long time, but it's not a lot of time for gathering some data. So we have only recently launched sort of a patient stories or success stories campaign where we're trying to hear more from payers what they're seeing. And you know, they may be success stories or they may be challenges, but we want to hear both. So, and if folks have anything to share with us, they should certainly email, again, that longest email address in the world that's still up on your screen. Send us an email and tell us about, you know, your story, your success or challenge. We want to hear both. But we are still gathering some of that data. So I can't tell you too much in that regard. But I can tell you we've had some payers who have self-reported that they did not meet the deadline or that they have challenges, and they have told us what they're doing to overcome those challenges and get to full implementation. In some cases, they have the API available, but they may not have all of the data included. Or some of them, you know, proactively reached out to say that the API would not be available, but here's the date that it would be. And for the most part, we've seen that those folks are following through, those entities are following through with making sure that they reach full implementation. So we've actually, I think, seen a lot of success there. I think there are particularly some state organizations that, due to contracting and contracting cycles and some limitations that they had, were a little bit farther behind, but again, are working on a plan to reach implementation. So I am confident that we're going to get to full implementation very shortly. I'm looking forward to having more patient stories and would be happy to share that at some, future event if there was an interest there. And then I also want to make a plug that I think from here out, we've done a lot of work engaging the payer community and also the app developers. I think there are about 68 apps listed on the Blue Button website that are, patient health apps that can also, I'm sure also working to integrate with other payers. But from here, we also have to work on educating our patients and letting them know that these are resources that are available to them. I think that next year's open enrollment period, lots of folks change health plans at the beginning of the year. It's an excellent time to start marketing to patients and trying to really use this as, like we were saying, this is a new healthcare marketplace where you're actually competing on patient conveniences and the patient experience. This is a great time to advertise that the API is available and what it can do for patients and really show what it can do for patients. And it doesn't just have to be patients accessing the data. It can also be patients, I've seen tools where patients can input their Blue Button information and the tool churns through the Blue Button information to say, oh, you've had the following claims. Based on your claims history, we think that this health plan is going to be the next best fit for you. So when you enroll next time, we think this is the best fit for you. That's not a patient health app specifically, but it is a tool that can help patients making better informed decisions. I expect to see more of that in the future. And I think that those types of apps will help to engage patients and help to really increase the success of these API implementations.
Great. So we
Hey,
actually have
Janice,
That's your job.
Yep.
That was
Yep.
that was an action item for you all to work on patient engagement and building better tools for them.
A little bit of ping pong going on here. So we're going to take just a quick commercial break. We're going to give Alex a chance to get some air and maybe catch a drink of water or something. And we're going to pop up a quick survey just to see how people are feeling about the webinar today. So please take a minute to fill that out, and then we'll jump right back to the questions, and we'll wrap up by 2:30.
Yep. And just as a heads up for folks who asked questions, we are not going to get everything. I am going to do my best to combine bunches of questions so we get through as much as possible. Alex, I know CMS is really good about answering questions generally. If we send some additional questions either to you or to that email address, would that be okay?
That would be wonderful. Yeah, thank you.
All right. And should we send them to you directly or should we send them?
I send them to, we do a lot of tracking through the high IG email box. So I prefer if folks send them there for our tracking purposes.
All right.
And also
We'll
so
do
that
that.
we make sure nobody falls through the cracks.
All right. Sounds good. But I'll do my best to get through a few more, and there's a bunch of things that go in groups. We'll try to combine them and maybe get to 2 or 3 more big topics.
All right, looks like we've got 100% answered, so we will end the poll, and we won't share the results with everyone, but if anybody's curious, feel free to reach out and we'll let you know how things went today. So we will return back to questions, Q&A, but again, want to keep an eye on the time. We're about 2:13, and we'll just maybe, Janice, try to kind of consolidate and wrap
Yep,
up. the higher
I'm
points at this
planning on
point.
doing that. So the next
Sounds good.
topic to cover is specifics about the data itself. So I'm gonna again group a bunch of stuff together in hopes to consolidate. Can you talk to requirements around absorbing data received via peer-to-peer exchange? Are they expected to be available via patient access APIs? Are they expected to be included in subsequent peer-to-peer requests? And then the next piece of that is, are there plans to support incoming patient data either via app or app entry or from home health devices or apps or things like that? And then can you clarify policies around extracting US CDI, US core data from unstructured documents for API exchange? I bet you get that one a lot. And that's it. So like that group of stuff about the data itself.
So you did break up a tiny bit at the very beginning, but I think I got the gist of the question. Tell me if I go awry. But for the payer-to-payer data exchange, that includes from first interoperability rule includes only the US CDI data that would be exchanged between payers. And that data, like I said, since it's not through an API, could come in a variety of formats. The thought there is that the data would continue to follow the patient. So unfortunately, that does mean that if a payer sends a bunch of PDFs to another payer, that's kind of what that new payer has to work with. That said, the new payer is not required to bring in any of that unstructured data into the API, but they are sort of required to house and have that data available for the patient. We understand that they may not be able to put that into the FHIR format and then continue to, and put it into the API or even to send it forward in an API. But the idea is that that data is available for the patient. As we mentioned in the second interoperability rule, we were really looking at a way to move all the data into an API format so that payers didn't have some of those challenges of accepting multiple forms of data. We also, as you saw in that second rule, proposed that there would be more data included beyond the US CDI, so that claims and encounter data as well as the prior authorization decisions. So that would make that much more comprehensive data that is following the patient from payer to payer and in a standardized electronic format that would then allow the patient or the payer to make that data available through the patient access API and on to the next payer. And I think I forgot the rest of your question.
Actually, while I'm getting you there, can you just clarify? Because that's actually a different answer than I've heard in the past. So I just want to clarify. You're saying that the data that comes in from payer-payer exchange that does not come in via FHIR does not have to be, that is US CDI data, does not have to be converted and included in future patient access APIs requests for that patient or passed on to future payers. Is that what I heard?
So the intent of the policy is that the patient has access to this data and that it can continue to follow them from one payer to the next. So the intent of the policy would dictate that a payer should make a best effort to make that data available through the patient access API and continue to send it on to the other payers. However, we did note in the rule that we understand that if you're receiving large amounts of data from another payer, that the new payer should not carry the burden of essentially translating that or converting that data into FHIR. And I believe this is in our FAQ document as well. So please take a look there because then you'll get the actual in writing formal answer that's been cleared. But again, the intent of the policy is making all of this data information available. And we would really love to see that. But the challenges, we do understand the technical challenges with implementing that and converting some of that data.
All right, so the other pieces were, are there any plans to support incoming patient data in future exchanges?
I could certainly see that as being a valuable add, but right now there's nothing that we can speak to on that.
All right, let's move on. So the next topic is SDOH. We had a couple of questions around SDOH, and the first one is SDOH are increasing in importance, but how they will be used to improve healthcare for disadvantaged persons is unclear. What role will CMS take on how SDOH data is collected, exchanged, and used? And if you give me 1 second while you think about that, let me go down to the other question we had that was related. Are there plans to work with other agencies to expand health standards to community organizations or other providers of SDOH services? So kind of two parts there.
Yeah, so let's see, there has recently been a significantly increased focus on the SDOH data. Actually, one of the boards that we sit on is the Board of the Gravity Project, which focuses on a lot of work around this particular data, and the FHIR accelerator for this data. And I can definitely see an interest in finding better ways of collecting this data, although we don't currently have any policies in place or any proposed rules out there about the collection of this data. I think that, it's really a multi-parter here is like, changing the way that providers work with patients to be able to collect some of this data and make that do we make that a requirement of the programs? There's a lot of questions around the best way to collect this data, and that's something that I think right now we're in the research and discovery phase, and that's why we're working with folks like the Gravity Project and others to determine what is CMS's role here. And I know there's also, discussion of the SDOH data and the USCDI. So going back to the USCDI discussion that we had earlier. So lots of work being done here. Nothing in terms of policy or changing any requirements at this point. Sort of the same answer for the second question. I think there's lots of work being done, and we're going to continue to do research and talk with stakeholders in this space, but there's probably not much more that we can share or that we have in the works at this point.
All right. So really quickly, if possible, how do you see the patient-centric efforts of CMS aligning or interacting with ONC's focus on TEFCA, which is really different?
Yes. So ONC's done a lot of work on TEFCA and recently, kind of relaunched some of their efforts. And I think CMS and ONC will continue to work together to find ways that this supports both of our efforts. Right now, though, I think there's probably, until there's a really formal TEFCA, there's nothing, can't propose something that doesn't fully exist yet. Yeah, we'll continue to work with ONC. We know this has been a huge driver of theirs for several years, and they've recently redoubled their efforts, and we certainly want to be there to support.
All right. So really, so we had a question around state Medicaid plans. Are they required to adhere to the rules? And it seems like Medicaid is often a laggard in these implementations. Is there anything that you're doing to try to prevent that if they are required to adhere?
Can you say that second part again?
Medicaid is often a laggard in implementations. Are you doing anything to help them not lag if they are required to adhere to the rules?
Okay, great. So Medicaid is subject to the policies of the rule, the two API policies, patient access and provider directory. They were not actually included in the payer-to-payer data exchange. However, we did, if you go to our website, the first link on your screen there, and scroll down to, or just, I think if you Control F the word state, it'll take you pretty much right to the link. There is a state Medicaid letter that went out encouraging the state to adopt the payer-to-payer policies as well. Particularly we have with patients who churn, who move in and out of these programs, we want to make sure they're able to take their data with them when they go into a Medicaid or leave a Medicaid program. So we would certainly like to see states engaging in that policy, even though it was not required of them in the rule. In terms of states lagging, I think I did mention that there were some states, because of contract cycles and other issues, were not able to meet the initial deadline, but are tracking to a compliance plan that would allow them to come into compliance with the rules, and we'll continue to monitor that. But we really, more so, we're focused on supporting the states and ensuring that they have access to the implementation information that they need. So there are lots of free resources out there. There are lots of resources that CMS has through our work with the fire accelerators. We want to make sure that all of that is available to the states as well, and ensure that they are moving forward their implementations just like everyone else, because they are subject to the same rules, at least in terms of the two API policies.
All right, great. So last question. And as part of this answer or as a follow-on to this answer, feel free to add any final thoughts that you might have. Are there any other specific areas on your radar in burden reduction type activities beyond prior authorization and price transparency? Or are there any other projects or areas that you're focusing on that you're allowed to speak about or that you'd like to preview?
There are so many, and this is a great question to end on. I would love to do everything. If if I had a larger team and all the resources in the world, I would love to tackle a lot of different projects in this space to really just cut back on the burden, increase data exchange, and just get the focus back on the patient. Like, there should be no reason that providers have to hunt down data or, order additional tests for their patients if they can have that data available to them electronically. We have the technology and the resources available to make that happen. So why can't we just do it? And, so I'd love to spend some time in that on that space. You already mentioned prior authorization and price transparency, which are both great areas to focus in. And we obviously have talked a little bit about the work we're doing there. Additionally, so my one other pet project that I'll mention is, I'm always interested in improving provider directories or healthcare directories and the availability of information to support patients and interoperability and public health. I think that having a directory that connects all of healthcare can be a really valuable thing. And that's something that, I will personally continue to work on in my role, but I think that there are lots of projects that deserve more attention, and we'll just have to go through them as we're able to, and as those resources are available. So, but I think, there's a role that CMS has to play in regulating and in this space and helping to align industry. We also use, our convening abilities to bring stakeholders together, often like we just had a Connect-a-thon back in July, and, bringing people together to test some of the FHIR implementation guides and have, further conversations on other things to develop. But then industry has a role to play too. I mean, I've already assigned you all some action items and working on patient education and encouraging patient adoption, but there's a ton of work that industry can do in this space to really support these efforts and look at our rules as being a baseline and say, okay, these are the minimum requirements. Now, how do we go above and beyond that? And how do we better support patients or make more data available, make more tools available? And we'd love to hear if people have ideas in that space, what you're doing. So, that goes for payers, that goes for providers who are trying to improve the quality of care that they provide to their patients or provide a better patient experience. What are you doing in that space? And how can we help? I think those are things that we really want to hear about, because we can regulate to an extent, but really you don't want a market that's driven entirely by regulation. You want a market that's driven by innovation and by the market forces and patient needs and your needs as a provider. So we really want to see a lot more of that, and probably a lot less of us talking in the future. But to the extent that we can be here to help with alignment or providing widespread resources, that's what we're here to do. So I will end on that. I will say this was the most efficient Q&A that I think I've ever done. So thanks for that. And I think we definitely
thank
used up
you.
all of our time.
I tried.
Well, we wanted to thank you, Alex, for your presentation and for your time today. We know how busy you are, and in particular, enduring that probably world's longest Q&A session that I think I've ever endured. But you handled it excellently, and really do appreciate your time on this. Great topics, great discussion. Thank you all for joining today. Feel free to come back anytime for more of our webinar presentations, and hopefully we'll have Alex back sometime in the future.
Yeah, we definitely love to hear you mention the patient and payer feedback that you were looking for on those. When you have some of that collated, we would love to hear about it.
Indeed.
Would love to share that. Thank you.
All right.
Alex.
All right.
Thank
Right.
you.
Thank
Take
you.
care, everyone. Thanks for
Bye.
joining.
Have a good one, everyone. Thanks for attending.
Bye-bye.